Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community, our province, and the country. Today, we're delighted to bring you Health System Responses to the Pandemic, Montreal Children's Hospital and McGill University Health Centre's Reflections and Lessons Learned. Just a reminder that we'll record all our webinars. As mentioned in the introductory video, please type your questions into the question box at any time, and I'll prompt you via the chat as well. And I'll pose the questions to our speaker at the end of the session. Now I'd like to introduce our speaker for today. Margaret Ruddy is the Associate Director of Nursing of Montreal Children's Hospital and the Women's Health Mission of the McGill University Health Centre. Maggie joined Montreal Children's Hospital as a critical care nurse, then as a member of the Nursing Activities Coordinator team, and then she rose to the position of nurse manager in pediatric ICU at the Montreal Children's Hospital until being appointed Associate Director of Nursing. It's my pleasure to pass the mic to Maggie.
Bonjour tout le monde, and thank you for joining me today and allowing me to share the results and recommendations that came from a study, a quality improvement study that myself and several colleagues had undertaken in May last year. So I would like to just share my screen. Hopefully this goes here. Okay, and we'll start the show. So as Paula had mentioned, that we are going to be looking at some of the reflections and lessons learned that came through the first wave. As you all remember, that first few months were very chaotic, and we thought we would like to study that as we move forward during the pandemic. I would like to make two acknowledgements. This study was not undertaken by me alone, but with the help of several colleagues. So I worked on this study with Dr. Alain Khalil, pediatric emergentologist, director of education at McGill, and also an expert in disaster medicine, Dr. Valérie Aumier, adult emergentologist, also an expert in disaster medicine, and Dr. Frank Carnevale, nurse, ethicist, and researcher whose contribution to this study was key. In addition, I would like to make our own land acknowledgement here in Montreal. So welcome to Montreal, everyone. And our land acknowledgement is that McGill University is situated on the traditional territory of the Kanakaha, a place which has long served as a site of meeting and exchange amongst the nations. We recognize and respect the Kanakaha as the traditional custodians of the lands and waters on which we meet today. So the Montreal Children's Hospital is a 152-bed tertiary quaternary care hospital that functions within a network of hospitals known as the McGill University Health Centre. So it was as part of the MUHC, which is known as, that the Children's Hospital participated in this quality improvement project with the full support of our administration at the MUHC level. So I would like to do a little bit of review. I'm sure many of these dates are etched in everybody's head. So in early 2020, here in Montreal, we saw our first COVID-19 patient who arrived in Verdun Hospital on February 25th. Then March 10th, we had the global pandemic was declared. And then shortly after, Prime Minister Trudeau urged all Canadians to come home on March the 16th. As Quebecers returned from Europe and the sunnier skies, which we traditionally go to for our spring vacation, home quarantines were imposed, causing the first disruption to our healthcare workforces and adaptation to teletravail to keep health organizations functioning. Much confusion and concern grew as healthcare workers watched the pandemic evolving in the US and in Europe in particular. The MUHC rallied to manage the evolving crisis and to continue providing care in the new reality. Every hour brought new information, new directives, and it created a rapidity of changing priorities and practice that was very stressful and difficult to manage for our healthcare professionals. In addition, each healthcare worker was facing multiple complexities and challenges in domestic life: no daycare, no school, unable to look after elderly adults in their personal life, and then adding that to the professional life really gave a heightened sense of stress within the workforce. So given the unprecedented features of this pandemic and the related implications for emergency measures at the MUHC, this project was aimed to document and analyse the operational accounts of our staff and our managers during the rollout of the MUHC response to this public health emergency. We analysed data prospectively to identify problems that might require immediate attention, so-called red flags, and then to identify strengths and build on those and the limitations of the MUHC's responses, as well as the needed improvements for future emergency measures and for our preparedness for all emergency measures. So the challenge in starting a study in the middle of a pandemic when chaos is reigning is, of course, for everyone. Who has the time right now? We found that changes were so frequent that it was difficult to establish whether the last intervention was helpful or not. So it was really important that this survey was kept simple and concise, and we needed to have open questions that allowed for as much data to be gathered as possible. We also wanted to make sure that the questions were applicable to all personnel and not just to clinicians. So the responses we hoped would help the MUHC modify its response with real-time data right during the pandemic rather than retrospectively. So we chose 3 simple questions. What do you think went well? What can be improved? And what is causing you to worry the most? So we were rather overwhelmed with the amount of respondents that we received. So in the space of 3 weeks, we received over 738 responses from every MUH site. So all 6 sites were surveyed. 30 occupations and service departments were representative. And one of our concerns was the red flags that we mentioned earlier, but nothing was identified in these responses that required an immediate intervention. So this large survey response gives data that comes from every sector. And what was clear was that the majority of the participants, they provided rich and detailed responses to the survey, which also surprised us. They took the time to give long narrative responses. They talked about personal experiences, professional concerns, and their general observations gathered over the first months of the pandemic response. The participants' reflections demonstrated that they were concerned for the safety and well-being not only of themselves, but for their loved ones, their colleagues, their patients and families during this ever-evolving situation. And the sense of caring for the collective was present throughout all of the project results, through every discipline as well. Participants identified limitations in a compassionate and respectful manner, and they provided concrete examples of how the MUHC might improve the response. They also expressed their belief in the MUHC's community's ability to address the pandemic-related issues safely and effectively. This is just a little photo op for some of our colleagues here at the Children. So the results, again, we were very surprised. People were very prolific in the amount of information they shared. And really, in the end, the key results were round about fear for loved ones, risk of exposure, and access to PPE. So some of the strengths that were identified was the immediate response of the MUHC. They felt that they appreciated the quick establishment of the screening at the entrances, as well as the shutdown of non-urgent health services and consequent transition to telehealth where possible. The actions supported the implementation of physical distancing and other IPC measures in the workplace. Another common strength that was identified was the weekly webinars that we had started very early on. They especially appreciated the opportunity to answer questions and receive answers, as it gave the opportunity for members to voice their concerns and actively participate in their response outside of their usual day-to-day roles. These webinars are exemplary of what many participants reported desiring. They wanted transparency around current trends, future plans and uncertainties, as well as a more egalitarian approach to discussions and decision-making. You know, we're all in this together. We all need to work towards the solutions and the improvements. I think we just discussed these in my previous slide. So we did an analysis of what different professions found was working well and what they were most worried about. So we kind of drilled down into the qualitative data to respond to that. So nurses were the group most likely to express satisfaction with system-wide communication, the webinars, the town halls and the emails, but paradoxically also most likely to suggest improvements to communication, especially with frontline staff. And this is something that I think is interesting, we can bring up in the discussion later on. One nurse described it as this: while leadership teams met daily, little was passed directly onto nursing teams at the front, and nursing was often left to be dealt with on a unit by unit basis. So frontline staff expressed that they felt in the dark and not really quite understanding the hospital response plan. Physicians, however, met on a daily basis with their DPS, but nurses did not have the same access at all, or any access to the ADON. It was all filtered through a management model. So the nurses were also the group that they were most likely to say they were worried about the institutional preparation. Struggles that we have, and I'm sure other facilities had this, was lack of access to negative pressure rooms should they be required. Physicians were the most likely group to express satisfaction with coordination of the response, but were most likely to suggest improvements to infection control measures. And there was a dissatisfaction with differing directives coming from infection control, sometimes that weren't the same as the provincial directives. Sometimes this sort of confusion around about infection control left physicians feeling overburdened and under-supported in the task of having to translate the evidence into practice. Alternately, infection control measures were often praised by lab staff and medical technology. They felt very confident in the infection control measures. A wide range of measures were identified as strength by the medical technologists. They appreciated quick access to PPE, the physical distancing, the closing of clinics, which really affected their workload. Social workers were most likely to express satisfaction with their departmental level communication, as well as having access to additional staff supports. So there were psychosocial teams put in place to allow people to access should they be experiencing any emotional distress. Social workers, along with the psychologists, were also the most likely to be worried about transmission to staff and their families back home. So we also drilled down into the data by site. So we've looked at some of the highlights from the different sites. So Lachine is an adult facility that is mostly secondary care. They do have an OR and an ER and a smaller ICU, as well as some long-term care beds. The Neuro, the MNH, is our neurological institute, so it has surgical and neurology patients there. The General is our trauma centre, and the Montreal Children's Hospital is us, and we're also a trauma centre here. So at the Children's, the care professionals were most likely to praise the team for departmental level communication, as well as the additional supports for staff during the response. Many of the care professionals at the MCH appreciated the daily huddles that we put in place that took place because they provided a space for colleagues to share information, express concerns, and address emerging issues. Lachine care professionals were the most likely to praise the coordination of the pandemic response. Two participants from Lachine said there was a calm, methodical approach to ramping up services, making sure that the needs of patients and staff were addressed. Understanding the risks of related to flaws in coordinating staff distribution, family doctors always already working at multiple sites, and fast implementation of telemedicine with proper support. At the Montreal General, care professionals were the most likely to suggest improvements to infection control. That's also interesting to bring out. The actual physical structure of the General has some specific challenges related to infection control. And one participant from the General said, infection control was contradictory depending on who you spoke to. And there was not an availability of health IPC professionals necessarily to clarify or to validate what the latest memo had been. And there was a feeling that some of the recommendations came down didn't make sense, and we alluded to this earlier, and didn't necessarily look at national or international recommendations. There was a lot of confusing information that made people feel very uneasy. A physician said that care service professionals are worried about the delayed measures outside of COVID designated units. So a lot of the measures were put in place very quickly where the patients were going to go, but the fear was there that if we don't organize ourselves well to protect everybody, we might find ourselves with a different crisis on our hands. At first, the criteria for patient screening didn't correspond to the reality for many people coming into the adult facility, because many elderly people came in with atypical symptoms, and we weren't allowed to screen them because they didn't fit the criteria at the time. At the neuro, care professionals were the most likely to express worry about PPE availability for a wide range of colleagues. So some of the suggested improvements came from several areas. So they're coordination, communication, as well as infection control. So in terms of the coordination, there are three elements that came forward as the frequent themes: are redeployment of staff, general preparedness, and access to being able to do working from home and having the technology required. So many participants who referred to response coordination spoke of this theme generally, with preparation, speed of execution, organization, and delays, and with reference to multiple levels, i.e. the individual department, hospital-wide, and CCMU, our coordination committee. However, a comparison of the sub-themes in this qualitative data revealed that some aspects of coordination that received differing levels of praise and criticism. In terms of planning and preparation, participants recognized proactive actions by fellow colleagues and spoke positively about surge planning, the creation of the negative pressure rooms, COVID unit preparation and management, as well as support and management of the ERs and ICU. Some participants noted that the quickness of the MUHC response in these actions, along with others, and this so-called sub-theme of quick response overlaps with other themes. The quick response that some participants feel made them feel more protected along with their patients and families. One ICU nurse stated, "My director took very seriously the health risk to our team members in our department, they responded appropriately and quickly to safeguard our health and that of our patients. I felt that I was in good hands. Perceived limitations to planning and preparation included short and long-term actions. The short-term actions that participants perceived could have taken place earlier was that once the pandemic was declared, that the protocol development and plans for IT changes didn't move fast enough. Some respondents compared themselves to other facilities within the Montreal area and said that, you know, maybe they had their protocols ready earlier, and we also have physicians who work in multiple sites, so they see the differences in response. Longer term suggestions revolved around the concept of pandemic preparedness, and I'm sure this will be a topic for the group after the presentation. One participant who worked in radiology said, if this should ever happen again, let's hope not, we need to be better prepared for any type of disaster and not just an infection disaster. A major push for disaster preparedness is required with a larger team and lots of funding, and it can't be put on the shoulders of already thinly spread out clinical and administrative staff. One of the other strengths that was identified was the redeployment of staff. Participants spoke positively about the speed of redeployment, the scheduling, the balancing of work loads, and receiving support during role changes, support from working in a pediatric centre, for instance, and being transferred to work in an adult centre within our network. Participants expressed concern about the lack of choice, however, about where they got sent, and this was part of a government decree that permitted the movement of nursing staff to areas of need, and not necessarily where they would choose to go and work. So generally we would ask people to volunteer for redeployment before that would go into place. So the actual forced displacement or redeployment was very minimal for the MUHC, which we were very grateful for. Some participants, particularly those working in admin, they experienced a slower transition than they would have liked to go to telework. Getting the IT infrastructure so people could access hospital software from home was labor intensive for our IT department. And I think this comes under the theme that, you know, for further emergencies, this might be very key, that people can work from home if we're overwhelmed within the hospital. Participants who spoke positively about leadership praised the leaders, both local and senior, who they said seemed visible, knowledgeable, in control and empathetic. One family physician praised senior leadership during the response. He said the actions of our CEO, Dr. Feller, and his senior executive leadership and management team included regular visits to clinical teams and in the community has been inspiring and effective in rallying team spirit and reducing anxiety amongst staff. Members of the senior leadership team were mentioned by name in many of the survey responses and in related to leadership, and participants within this sub-theme usually spoke about the senior leaders' increased visibility through in-person visits as well as virtual town halls. This is a group of my colleagues who work in the emergency department. So further to suggested improvements, these came mostly around institutional communication. And again, there were some paradoxes in the responses. There was about a third of the participants found strengths and also limitations within system-wide communication during the pandemic response. And I'd be happy to talk a little bit further about that in the question and answer period. The weekly virtual town halls were really appreciated by the participants for the efforts to increase transparency, but many people felt that the webinars weren't accessible to the frontline staff, and that was problematic. Again, as we have said before, question and answer periods and this interaction and feeling of contributing to outcomes and improvements was very positive for all of the participants. One of our, I guess, vulnerabilities came about with email, and I think there was both a need for information and email, but then the email was coming from so many different places that people felt like overwhelmed, and they didn't know which email to open and what was most important. So we can talk about how we have addressed that issue later on in the presentation. The creation of daily updates within our intranet portal helped with some of that. There was a COVID link that people could go on and get the most up-to-date information. And again, the streamlining of information was something that was asked for, because people just had they wanted communication, but they didn't know how to prioritize it as it came in. And I think one of the big challenges came about the timing of communication and protocol changes. So one nurse described the timing of protocol changes. The protocols were coming out so quickly, and often it was clear that they had been written by people who are far removed from clinical area. And there were multiple times that it was clear that this protocol wasn't going to work in a particular setting. So then there was a delay, the protocol had to be revised, and then multiple changes led to confusion because people didn't know which protocol to follow. So one of the recommendations is no more Friday night new protocols. We really wanted to make sure that there was staff support and resources to help people implement the new protocols. So unless something was emergent and had to be done right away, in which case then we would mobilize resources to be around for the protocol change. The tendency came to not do any more Friday nights or Friday evening protocol changes. The other big area of suggested improvement was through infection prevention and control. As we mentioned before, one of the big fears of all of the participants was of becoming sick, making their patients sick, or making their own family members sick. So 35% of participants expressed satisfaction with infection prevention and control and training in their workplace. And one participant reported, "I believe we prepared very well for the pandemic with the information we had at the time." And as we had mentioned, things were changing very rapidly. We started with early fit testing, we had simulations, we educated our staff along with infection control, and we wrote many algorithms and updated them weekly. Other responses echoed this appreciation in the creation, implementation, and evaluation of the protocols. Additional aspects praised the reinforcement of hand washing at every opportunity we had, and mask wearing, and the restriction of visitor policies, which was, I'm sure, in every centre has been a challenge moving forward. The establishment of the hot and cold zones, the reduction of movement of staff through the hot and the cold zones. And I think there was some frustration that changes didn't happen fast enough. I think people, one quote said, "Hospital policies were too sluggish to respond to the scientific evidence," which we know was changing on an hourly basis at times, and to the realities on the ground. The policies and procedures were updated at a too slow a pace. Another commonly suggested improvement was guidelines for the PPE use. We encountered often people wanted to wear PPE all the time, and combined with the concern about PPE availability, this was an area of great stress for our teams. So I would like to take a little moment to sort of review some of the changes that we have made since receiving this feedback. As you know, we've now just coming out of the second wave, and I would be happy to say that a lot of things have improved. And I think the feedback at an early point in our pandemic journey, I think, was really, really important. So the institutional coordination has really improved. People know there's a regular meeting to look at which beds are going to be COVID, MUHC wide, which are going to be non-COVID, and to look at our capacity to look after the patients and meet the government guidelines for ensuring ICU access. There's a central process for redeployed staff, which allows conversations between departments about where the needs are most. And the majority, as I mentioned, the majority of our redeployment has been voluntary. People, they've put out a call, and we've even redeployed to areas outworth the MUHC within Quebec. The teleworking infrastructure is much more robust, and I think the expectations of what is expected of individuals when you're working from home in terms of availability is much clearer now. For me personally, and I think for our group, one of the great wins of the pandemic has been the processes of the CCMU, which is our central coordination decision-making body, which is very, very smooth. The decision-making is all done through them, and people understand how a central coordination center works. So this has been a very positive effect. The ongoing webinars and town halls continue, and they are now open to everybody who has access, and they're recorded so that if people don't attend, that they have the ability to go into the portal and can look at it. As I mentioned before, there's no more Friday afternoon protocols released unless we have people available to help with the implementation. The intranet access has new policies that are updated regularly, the resources to make sure that there's no draft 1 or draft 2 protocols there. And there's a clear message about what needs to be distributed, like for managers to share with the frontline staff. So central memos come out that clearly state this needs to be given to all of your department and your team. For infection control, one of the big stressors for occupational health was being able to cope with the huge capacity increase that was required to deal with people reporting symptoms, reporting a family member with symptoms, following up on results. So we rapidly enhanced the resources for what's called our 4-4 flu line, which is the information line that people call should they have a COVID-related question regarding their presence at work. The guidelines for cleaning between patients has taken place, and we have had massive reconfiguration of our waiting areas, of our office areas, and to ensure social distancing. There's plexiglass everywhere, and in addition, one of the key wins, I think, was the establishment of the PPE task force, which has a dashboard that allows people to look and see, what is the availability, what are our vulnerabilities in terms of N95 needs, visor needs, and that increased transparency has really been a positive outcome for our teams. So this is just another one of our colleagues from the Montreal Children's. I would like to take a moment to thank Dr. Frank Carnevale for his methodological support, his data collection, and helping us with the design to get all of this data assembled and gathered in the middle of a pandemic. Key to the data collection were his data analyst, Carly Heck, and Matthew Bennett of the Voice Childhood Ethics Research Program at McGill University, who Frank had generously allowed us to get their support to run this project. And for me and from my team, we would like to thank the dedicated community of the MUHC who continue to ensure best care for life for our patients and for our families during these challenging times. Thank you.
Thank you, Maggie. This is my cue to prompt everyone to get their questions into the question box now that you're thinking about them. There was one clarifying question about whether the RVH was included in the group of organizations surveyed.
Yes, they were, but it kind of got jumbled like into adult there. But I can bring out the RVH data as well.
I think the question came up when the slide where you had differences by site, Maggie, and the RVH wasn't there. But if I'm correct, I remember that it's because there weren't any really outstanding concerns that came out particularly out of the RVH. That's why we didn't list it there.
Yep. So, I mean, there was a big participation. There was 321 responses from the RVH, so they were part of the survey. So the slide probably should have said MGH RVH.
Yeah.
Yep.
And also I invite all of our attendees to use the chat box to share what works, you know, your reflections on what you've heard, how this played out in your organization or hospital or other institution, and what changes you see as sustaining beyond the pandemic, which brings me to a question for both you, Maggie and Elaine, around what of these changes do you see as sort of temporary and which ones do you hope to sustain moving forward?
I think Elaine and I would both agree that I think the improvement to the processes in our central coordination, I think, has been solid. It's been something we've really been working hard to try and do. And there's nothing like necessity to bring creativity and to move things forward. So I think that's something that would you agree, Elaine, that we would hope to keep?
Absolutely. Yeah, absolutely. I think it's been a number of years that we've been trying to work towards a central coordination structure that was, well, for lack of a better term, more structured. And here we really, it really came through. I guess a couple of things, like often happened a little bit serendipitously, in the sense that last fall we hired a new coordinator of emergency measures, and this person had a very clear idea of where and how a coordination should happen centrally, and she brought that structure in. We had practiced it during simulations, and we saw really well the fruit of that, and then the practice of that throughout the simulation. I think what I should say is that this, we call it the CCMU or the EMCC, the Emergency Measures Coordination Center, opened immediately, even before the pandemic was officially announced. And at one point we were meeting twice daily for an hour each day, 7 days a week. And so I can tell you that that kind of intense coordination and communication was very key to the initial, kind of organization. Things like I don't remember how many negative pressure beds we got up and running within a very short period of time. We had a capacity for whatever the ministry was asking us for in terms of COVID beds, that was up and running within 10 days. So when an institution this large has to move that quickly, I would say that EMCC was absolutely key to that functioning.
Makes a lot of sense that you were a little bit ahead of the curve that way.
Yeah.
What surprised you most about the results of the survey?
I think there was some ambivalence. There's people there, and it was difficult to drill down on that. I found that this piece around communication, which is a struggle in any big organization, is that what is communication? I can say culturally in the children's, within the children's mission, the children's hospital, communication is more face-to-face. We don't have a culture of saying, I've read the email, but people like to communicate. So that was gone. So there was almost like I think people had to develop a new habit of receiving communication and go into I need to go and find the information, as opposed to it being given to them. So that was a bit of a culture shift. And I think that explains the results, is like, the same amount of people said communication was bad as said it was good, because, and I think the other piece was, people want to be communicated with, but there's an element that there's just too much. And I think that, I think the impact of too much information with too much ambiguity could actually have the opposite response. I don't know about you, Ellen.
Yeah, I think also added to that, if we looked at different groups of health professionals within, the 12,000 employees, different people are used to getting information from different sources, right? So, for example, the physicians don't routinely access the intranet, whereas now that was the main source of the most up-to-date, reliable information on protocol changes and things like that. So it really required a change in practice that way. Whereas, other health professionals first thing they do when they come to their desk in the morning is look at the intranet, so they would immediately have that information. And I think that accounted probably for some of the discrepancies and kind of ambivalence that we perceived in the survey.
Well, that makes sense.
Mm-hmm.
And are there still further changes you would like to implement as a result of the survey results?
I think so. These would be other positive growth things, like so a communication style, like so to maintain that would be good. I would like to. I think if the idea of having a dashboard where people can find out truly, like rather than wonder if there's going to be enough masks, I think that kind of transparency is, I think, something that we can incorporate moving forward. I think, I mean, it was definitely a first. There's many things that we just had to try and move forward. I think hopefully we never have to go through a massive redeployment of staff, because that's always difficult for people. So I think, should we have to do it, I think maybe it's, you know, we know how to activate that process. So I think ongoing is really just to keep the communication. So it's not, I think, to build on what we've learned about communication within a big organization. I mean, the MUHC across is like about 12,000 employees and physicians. It's a lot of people to be able to keep in the loop moving forward.
Yeah, no small feat.
No.
Paula,
oh, go ahead. Sorry.
Oh, sorry, Paula. I was just going to say, before you asked what we'd like, what we hope stays and what disappears, I think that we've made bounds in terms of the development of telework, anything, telework, telecommunications, tele-teaching. So in terms of, in my role as Director of Education, I was really, one of the big changes in our practice is the move from in-person bedside teaching of various, I'm talking about all learners, right? Where you have, 12 nurses coming in as a cohort and dividing into 2 and 6 people going into a room and seeing a patient. This is not possible anymore. So our teachers, our educators really had to pivot rapidly to try to incorporate these tele tools into their toolbox for teaching. And some of them, although, we prefer to examine a patient and palpate a belly and things like that, there are certain things that really are positive from that. So I do hope that some of those will remain. I believe they will. I hope, though, that it'll be in a more blended fashion very soon. The thing that I hope disappears is the extensive PPE that we have to wear, because honestly, it's very difficult to establish a relationship, as I'm sure everyone around this table can, with goggles, and you look like an alien when you come to the emergency room and meet a patient and they want nothing to do with you. So I really hope very soon we can stop that part of it.
Is the survey replicable in other contexts across the health system?
I think the survey was unique. You could use it, but I guess what's unique about the design of this, that it was done in real time. It wasn't retrospective data. So the purpose of it was to capture everything's moving so fast. We need to figure out what's going on. So I mean, I think it could be applied, but it would need to be in the midst of what's going on, as opposed to after. I think the questions need to be asked at the same time. Would you agree, Ilan?
Yeah, absolutely. We did consider, when we were designing the study, we did consider repeating the survey at different periods, but we decided against it just because there was really an information and communication overload, and we were worried about the quality of the data that we would get. I mean, I think it would have been interesting to repeat the survey, to replicate it as you suggested, Paula, say in the second wave, because I'm sure the concerns would have been quite different than in the first wave. But we didn't do it. It was really, I think it would have been probably too much.
It is actually quite interesting that you got the responses that you got in the middle of what is really a crisis. And if folks were overloaded and unable to get to webinars, or even their email, that they responded to this survey is an important finding all by itself.
Yeah.
I think, going back to that was the question you asked, and one I had responded, communication, but I think the fact that 738 people took time not just to click the boxes, but actually to write their stories and to write what they're really worried about, it spoke to the engagement of people. I think it spoke to their fear and their worries about that. But I think there was a genuine response. And like I said, I guess one of our concerns going in was that we would get a lot of negative, and I think what was really overwhelming is people, they saw the efforts that were being made. They were constructive in their narrative responses. So I mean, I guess that kind of response level was quite huge, given that people were so exhausted.
Yeah, and probably a need to not vent, but share their concerns, not be the only one, contribute to the betterment of the system that they're continuing to work in, for sure.
Yeah.
What level of administrative support did this require, if any? And what has been administration's response post-survey?
Okay, so this is where the assistance of Dr. Frank Carnevale were huge. They helped us with the data analysis, so they really carried the burden of this. So we are forever grateful, and they did the analysis very quickly, because that was our other concern. Is if this is real-time data, we want to analyze it and act on it in case there's something we really need to change right away. So those two, they worked on it for several weeks, and yeah, it was quite intensive.
Yeah, I can imagine.
Mm-hmm.
Amidst everything else that was going on.
Yeah.
Well, there's a question from Doreen Evans York. I don't know if you saw that in the chat.
Oh, whether other members of the Allied Health Services team, social workers, psychologists, were they invited to participate in the survey as well?
Everyone, yes. Everyone. We had housekeepers, lab technologists, everybody was invited to participate.
Yeah. And interesting that different disciplines might have different perspectives on concerns or even kudos.
Yes, yeah. And I think some of that was related to what the local department communication plans were. And as with many centres, a lot of our allied health colleagues were displaced to other centres here in Montreal. Many went to go and work in long-term care facilities when we were in the midst of the immediate crisis. So they were a group that really had to make massive changes in their role, and really gave huge service and huge support to our community partners.
Oh, wonderful. And in terms of, should there be, hopefully not, fingers crossed, another pandemic or a flare-up wave, would you see repeating the survey at another point in time? I know you talked about not doing it for the second wave, even though that might have been interesting, but if there is a future pandemic, do you see the need for such a survey? Have your changes eliminated the need for such of that?
You go, Ellen.
Oh, no, go ahead. I'll go after you.
Yeah, I think it would depend on the nature of the pandemic. I think some of the things are very clear, like so if it was more SARS airborne, like the concerns and it would be different. If it had a different
of the virus itself. And
yeah. I did want to back up to part of your original question, which I didn't ask, which was about our senior administration support. So our CEO and our associate CEO have been hugely supportive of this project. They actually allowed us to present the results back to the MUHC community for at one of the webinars. So they have been very and have taken a lot of the changes on board. Like they listened to the responses and made changes related to this.
That can have great impacts on staff perspective and morale, and to be listened to, heard, acted upon. Have you heard any feedback about staff response to the changes?
I would say in general that there is an uptake, and sometimes the concerns that are raised are different now. I would say,
yeah,
so transparency about PPE supply has been huge, the streamlining. So the concerns that are raised have a different quality to them. So and when people do have time to reflect, they do say, yeah, it's much better. I know where to find the information I need. I know who to call when I need a certain assistance. So I think there is an acknowledgement that the feedback has made a difference to our processes.
I think also the senior management, it's worthwhile mentioning that they mandated our quality department to actually execute a full formal review of the MUHC's response to the first wave. And they included this survey results in their review, that group of people. And that was presented also formally back to the MUHC staff in a webinar. And all of I would say most of the changes that were recommended were implemented. So if we were ever to do another survey in the future, I would say that the people that participated in this pandemic have it under their belt now, and so the questions would have to be different. I wouldn't have the same kind of open-ended questions. I would have probably more specific questions to further our pandemic response, to further improve it. I think we could hone in on the known areas of concern in a little bit more granularity.
Are you aware of other Canadian institutions that have done something similar, and how do your results compare?
I'm not aware of anyone who did something in real time.
Okay.
I know there are many studies out there about looking, if you had your time over and doing the retrospective work, but
right.
I'm not aware of anything else that was done in real time, in the midst of the pandemic.
Yeah,
but I would be curious to hear from the audience if what we found, if it grossly reflects what your experience was in your province or in your area, your institution.
And I encourage anyone in the audience to type away in the chat box or raise your hand and perhaps we can unmute you. There's not that many of us online. And where to from here?
With this, I think it would be nice to do a reflection back to the staff again. I would like to be able to sort of say, at the end of the pandemic, to kind of do a resume. Here you offered an opinion and and compile it with the quality department's information and say, here's where you made a difference. And I think to really allow our respondents to say, expressing your opinion, improved care, improved processes, and improved outcomes for everybody.
Yeah, I think that is a very important closing of the loop there, so staff will feel heard. Any last minute reflections, tips, advice? Would you do it again if you had to?
If I had the same support, then
yes.
Yeah, and I think that was the biggest thing is that as a group we realized this was something unprecedented for us as a society and also in our careers, and I think pushing ourselves to go the extra mile to try and collect the information at the time. I'm glad we did it, but it was really down to the support that we had from Dr. Carnevale and his team.
Yeah, it must have been overwhelming at the time. Like, kudos to you folks amidst everything else that everyone else was having to deal with to actually have the foresight to put the survey together. I think is fabulous.
Thank you.
There's no other questions and no other comments in the comment box. So thank you both so much, Maggie and Elaine, for sharing your time with us today. Thank you to all our members and other attendees for spending the time with us. We hope you depart with some practical knowledge to bring back to your organization. Join us on March 21st at 11 a.m. Eastern when we host our partners Solutions for Kids in Pain, or SKIP, and the Canadian Foundation for Healthcare Improvement to learn of innovations in pediatric pain management. Join us on March 25th at for our virtual complex care pop-up entitled All In, Creating Synergy in Pediatric Complex Care. Pardon me, Synergy in Pediatric Complex Care. Please visit children'shealthcarecanada.ca for more information or to register for that pop-up event. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. So thank you again for joining us today. Thanks to Maggie and Ellen for this presentation, and hopefully we'll see many of you back here on March 24th. Bye, everyone.